Bismillahirrahmanirrahim ji, we have another question here today. Before solving any USMLE question, I'm going to give you a pro tip, and that is always read the last line first if you want to actually save your time, because you have only got 1.5 minutes to solve a question. So just read the last line first. What is the most appropriate next step? And then immediately after, read the options. By reading the options, sorry, by reading the options, it will actually help you to diagnose what system are you actually dealing with. For example, swallowing function evaluation, bronchoscopic evaluation, CT of the chest, repeat chest radiograph, serum immunoglobulin testing. So it means either I'm dealing with cardio, either I'm dealing with respiration, or either I'm dealing with the GI. So I've narrowed down the diagnosis to three things. Let's see, what does the question say? A 58-year-old man presents with fever, productive cough, and chills for 3 days. So it is something which is acute. During the past 6 months, he has experienced multiple episodes of pneumonia that improved after antibiotic therapy. Okay, so whatever it is, it's improving after antibiotics, okay? And it is pneumonia, they told you. He has a 35-year pack smoking history. Temperature is this. Lung examination shows crackles over the right lower lung field. That's very buzzy for pneumonia. Okay, wherever you see crackles, 9 out of 10 times that's pneumonia. Chest radiograph demonstrates right lower lobe consolidation. Okay, they're handing you the diagnosis. The patient is treated with antibiotics and his fever and cough improve. Okay, that's good. However, persistent crackles remain on examination. So you have crackles that are not gone even after you treated with antibiotics. That's something that's a red flag, okay? Prior imaging from earlier infections reveals recurrent infiltrate involving the same right lower lung lobe region. Whatever this condition is, it's constantly involving only the one lobe of liver. For example, here you got this, these are the lungs. And whatever this condition is, it's involving only a single lobe of the lung. Not all of them, but a single lobe. For example, it's involving this lobe. In this question, it's involving this lobe. What are the reasons that pneumonia is occurring only in one single lobe and not occurring overall, and it's recurrent as well? And most importantly, it improves after antibiotics. There has to be something that's causing pneumonia in the same lung field. Before jumping to the questions, I want to ask you one question. What do you think the diagnosis is? If you're thinking about a mass, a neoplasm, a bronchiectasis, before that lung field, because you know what Hussein Sattar said? He said, if wherever there is an obstruction, you're gonna see inflammation in front of that area, because the debris, it cannot remove from this area. You know, the cilia cannot remove something out of a locked door. So it behaves like a locked door. The things cannot be, the debris cannot, the bacteria cannot be removed out. So it's constantly causing pneumonia in that particular lobe. What are the options? Let's rule them out. Swallowing function evaluation, that refers to the barium swallow. Okay, one thing that's for sure, and I'm gonna ask you to fix this in your brains. Wherever you see dysphagia in the stem, they say the patient is having difficulty in swallowing. What is the best next step in management? You have to choose this one. Swallowing function evaluation, the barium swallow. But here, I'm not seeing any swallowing dysfunction, so that surely is the wrong answer. Okay, rule this out. We are left with 4 options. Okay, I'm going to remove these two as well. For the end. Why am I removing this? I'm going to tell you. But first, I'm going to go through option D. Repeat chest radiograph after several weeks. Wrong answer. Why is this the wrong answer? Because the patient is having... That's a common sense question, okay? That's a common sense answer. The patient has a 35-year pack smoking history. He's 58-year-old. He is constantly having pneumonia, recurrent pneumonia in the same lung field. Now, any person with a normal brain has to think that there has to be something that's constantly causing pneumonia. And again, you have crackles on examination. You have infiltrates, again in the right lower lobe region. If you are having infiltrates, chest x-ray is not going to help, because chest x-ray has limited sensitivity. And secondly, you don't wait for weeks. If the thing is, constantly putting pressure on that person, that he's constantly coming to the hospital for the same reason, you don't wait for weeks. Okay, that's the big rule. So just rule this out as well. Thirdly, we have this option of serum immunoglobulin testing. I actually want you to focus on this option. If immunoglobulins are decreased, if there is a problem with the immune system, then why it is involving only a single lobe? Okay, that's a question. If it were an immune deficiency, it would not be involving a single lobe. It would be involving sometimes here, sometimes here, sometimes here. Okay, so you'll see pneumonia in different lung lobes if it were a problem of the immune system. So that's clearly a dead giveaway that I'm not the answer here. The answer lies in these two options, the bronchoscopic evaluation and CD of the chest, and this is what confuses most of the students. Whether you'll choose CD here or bronchoscopic evaluation, the correct answer here is option C, the CD imaging of the test. Now, before you panic, let me tell you something. You never do invasive studies before you see something. Okay? Bronchoscopy is good. You're going to see whatever is inside, but why do an invasive study when you can, easily get an image of what's happening inside the lungs? So just do a CD imaging, just see a mass. If you see a mass, if you if you see a neoplasm that's actually obstructing one of the bronchus and causing inflammation afterwards, if you see that, then you can do bronchoscopy and you can actually, put a bronchoscope in the patient's mouth, hurt him a lot, and then biopsy the lung tissue. That's actually neoplastic. Before seeing, you never do bronchoscopy. Bronchoscopy is the wrong answer here. Okay? Bronchoscopy would be correct answer here if the question stem mentioned that CD of the chest shows a mass in the hilar region. Okay? Even if it's not a neoplasm, it is a neoplasm here because he has a 35 pack year smoking history. That's a giveaway, okay? That's a giveaway for lung cancer because smoking is the number one cause of lung cancer. We all know this. What are the other reasons that will cause the pneumonia in the same lobe? Number one, neoplasm. Number two, bronchiectasis. Okay, if the tissues cannot be it cannot remove, the cilia is not working, and the debris are not removing, so it's gonna cause it in the same lobe. And thirdly, and most importantly, there's going to be an adenopathy. For example, there is lymph nodes enlargement, and if lymph nodes are enlarged, they push the bronchus. And if they push the bronchus, the secretions after that are not going to drain out. So that's again something that you have to see on CT as well. Anyhow, the take home message here is the CT is always the correct answer whenever you see pneumonia in a single lobe, because you have to see what is causing pneumonia in a single lobe. That is a common sense question. Okay, and after that you can do a bronchoscopic evaluation and you can actually look for this. So remove the barium study because it's not dysphagia. Remove the chest radiograph after several weeks. You never wait for weeks. Okay, it's a condition that requires imaging right now. Serum immunoglobulin testing. This would be a correct answer if you would have seen multiple pneumonias. Okay, sorry, not multiple pneumonias in different areas. And thirdly, you have to choose between bronchoscopic evaluation and the CT imaging of the chest. You do CT imaging, you do non-invasive studies first, then you have to move to bronchoscopic evaluation. If you like the video, just hit the like button and subscribe.